Good morning. I am Shelley Brownell, and welcome to the Group Corner webinar today. With us this morning are a couple of folks with the DirectHealth Connect program, which is a community-based program here in Cincinnati that we are excited to be a part of here at Cornerstone. Our usual housekeeping items. If you have any questions, please type those in the question box and we will answer those at the end of the presentation so we can be respectful of everyone's time. There's my slide. I am the Senior Director located in our Cincinnati office. Should you ever need to call me, there's my number, or you can call the main number and find me through the automated attendant if you have any questions, because I work with all the offices throughout the state of Ohio. Again, this morning we have DirectHealth Connect, and Patrick Shields is going to kick that off and then introduce Doug, who will be presenting the information this morning. Go ahead, Patrick.
Great. Thank you, Shelley. Thank you, everyone, for joining us this morning. Again, my name is Patrick Shields with DirectHealth Advisors. Myself and Doug Hetherington and his company, Health to Business, we helped bring a program called DirectHealth Connect to market a couple years ago, and we're excited about sharing some updates that we have to the program today that can help you win business and also keep current clients happy and protected from other brokers maybe edging into your territory. So a little bit of background about myself. I've been a broker like yourself for 15 plus years and also worked with Cornerstone. I had a great working relationship with them. And about 3 or 4 years ago, Doug and myself, we were able to start working with Mercy Healthcare and St. Elizabeth Healthcare and bring DirectHealth Connect to market. And we've also added several other unique cost containment programs that are totally different than anything that the BUCAs can provide, and are generating great savings. And as a result, we're able to bring phenomenal plan designs that were only available, that I can remember, back in the early 2000s with $0 deductibles, low co-pays, and low out-of-pockets when seeking care at our directly contracted providers. Not to say you can't seek care elsewhere. So plan members that are in service area or out are more than welcome to seek care at their preferred providers. They would have more of a traditional plan design that we'll get into in a little bit later. But so yeah, this is not an HMO where you have to seek care at Mercy or St. E's, but you are strongly incentivized through financial incentives to do so. And I'd like to introduce Doug Hetherington, who's the CEO founder of Health to Business. Doug, take it away.
Thanks, Patrick. Appreciate that. And do appreciate everyone being here today. So wanted to just kind of get after it and jump in and talk a little bit about what DirectHealth Connect is, but let's first hit where it came to be. Similar to you all, I was also an advisor and had an experience out here in Southern Idaho where I'm born and raised, to actually work with the provider community and develop a community-based health plan in this market. And it was through that experience that we realized that really most communities could benefit from this type of a strategy and opportunity. And so it was wonderful when we had the opportunity several years ago to partner with Patrick and go and have conversations with the local providers here in the greater Cincinnati area. And we're really excited to roll out DirectHealth Connect. DirectHealth Connect is really this idea of being able to work with both Mercy Health and St. Elizabeth Healthcare on a direct basis. And so if you think about kind of how we engage in healthcare today, I often refer to it as blindly financing our healthcare, which I think, if you really look at how we kind of function with the traditional carrier model, we really have no idea what's going into it other than very large checks that the employers are writing every month. And then I think there's a lot of frustration and questioning of what value it is that we're able to extract out of it. And so the idea here with DirectHealth Connect is this is the opportunity for the first time ever for your clients and prospects to really purchase directly from the healthcare providers themselves. And then what we've done is bake in for the other aspects that are non-provider related, what we think of as kind of best in class and very progressive options that just help deliver an experience for the three key stakeholders that we believe is very different. So today we're going to kind of focus on one of the products that we have designed within DirectHealth Connect. Level Fund Direct is what we refer to it as, and it really is a custom-built program designed primarily for the smaller group marketplace, 10 to 100, that we think just makes it very easy to sell DirectHealth Connect to your clients and prospects. So with that, we'll get started. So really quick from an agenda standpoint, what is a direct health partnership? A little bit about H2B. We'll get into some plan designs and then case studies. Ultimately, we want to make sure that we also highlight the prescription benefit program that's attached to this plan, and then the administrative side of it, which is of course important, and then certainly how are we ultimately protecting the employer and the members from those catastrophic losses. We'll discuss also a little bit about what it is, how you engage with Cornerstone to request a proposal for DirectHealth Connect, and then we'll obviously answer any questions at that time. All right, so let's jump in a little bit about what DirectHealth Connect is and kind of what we believe and who we are. And one of the things is that we believe that healthcare can be done a lot better than it is today. And we've seen that with 100+ clients that have jumped into our programs across the country, and where they've realized much better benefits while also experiencing the financial benefits of purchasing direct and offering best-in-class services to their employees and associates. When we discuss who we are, I think what's most important in this is to recognize that this, at the end of the day, really is about the key stakeholders, and we really believe that what shapes your community is, in many ways, the healthcare providers that we seek services from. And obviously, if you're on the Kentucky side of the river, there in northern Kentucky, you're very aware that St. Elizabeth is your option. They really are, kind of the premier health system, and probably have, well over 80% market share, which means, roughly 80 to 85% of the time, you're likely seeking services from either a St. Elizabeth provider or facility. And then as we move to the north side of the river into the greater Cincinnati area and even up through Springfield and Toledo, then you've also got access to Mercy Health, probably one of the largest health systems in Ohio, certainly most diverse, with even having locations into some of the other states across the eastern seaboard, with the Bon Secours side of the health system. And so we're very fortunate to have both of these health systems that have come together and partnered, because at the end of the day, they really do reflect healthcare for the greater Cincinnati area. One of the things that we're not, and there's going to be quite a few items that we'll cover in this today, which you may find intriguing, is we're not a traditional insurance carrier. We're very transparent in this model. We highlight not only where all the fees are, but we make sure that from an accounting standpoint, all of the dollars flow to the appropriate places. And we'll get into what that means a little bit more as we get into the presentation. Now, a few moments ago, I mentioned stakeholders, and I really do believe that this is key when you consider an opportunity like DirectHealth Connect, understanding who we're prioritizing in this. I often say when you look at the traditional health, especially fully insured model, really it's a shareholder focused model, meaning the people that are, kind of prioritized in that model are the owners of the large insurance companies, right? We think of them as BUCA, Blue Cross United, Cigna, Aetna, formerly Humana in the small group market. And everyone probably has their different players. But at the end of the day, they're really seeking to serve the shareholders that own those organizations. So at the end of the day, profits is what is motivating kind of the traditional model. And unfortunately, we really believe that flies in the face of kind of how this should be run. At the end of the day, we are talking about health care, and right, each and every one of us, our well-being. But that, there's certainly a lot of dollars being spent and invested from our employers. And then obviously, if you sit down and talk to the provider community, they're none too happy about kind of the denigration that is taking place on the health finance side of it through the fully insured model. And what we really mean by that is, higher out of pockets to where it's really put them into the collection business. And so our organization is all about not necessarily righting wrongs, but saying, hey, maybe we can do this a different way and actually prioritize what we believe are the three key stakeholders: the employers, the plan members or patients, as you might also think of them, and then of course the provider community. And that's not to say that we as advisors or former advisors are not, valued in this model. We certainly are. We're the vessels by which we're going to educate the community, the potential purchasers about a DirectHealth Connect. But at the end of the day, the ones that benefit, once the plan is up and going, really are going to be these three key stakeholders. All right, moving on. Just a little bit about health to business. So as I stated early on, we actually started up out here in southern Idaho. You can see that we've got, Idaho all in the dark blue there with H2B over it. And what that really represents is a program. And when we think of program, our kind of definition of that is that from a direct contracting standpoint, we have access that is robust enough that it could be considered a full network replacement. So this really is an alternative to purchasing a traditional PPO. We'll get into a little bit more about what that means and kind of from the actual plan perspective. But that is kind of how we define program. As you can see, we also have programs in several other states, Oregon, and then Missouri, certainly, Kansas, really kind of that East Kansas as you move into Kansas City. Down in Tennessee, and then as we move up into northern Kentucky and Ohio. We are growing rapidly. Some of the additional markets that we anticipate opening up in probably within the next 6 to 9 months, Arizona, both Phoenix and Tucson, and then we've got a lot of efforts down in the Memphis, Tennessee marketplace at this point. So we do expect that our access will continue to grow across the country. And certainly if your members were to find themselves in one of these marketplaces, they would be greeted with open arms, just as if they are right here in the Cincinnati marketplace with Mercy and St. Elizabeth. A little bit about what we do, and I think this is kind of important. So we really do kind of serve as the kind of program manager of DirectHealth Connect. In essence, we've sat down with these health systems, explained what a direct to employer model looks like, how our direct contracts function, and then how we operationalize that and provide the infrastructure for a program like DirectHealth Connect. So certainly, contract administration is important. Taking those contracts and actually putting them into a digital repricing system, making sure that claims get to where they're supposed to be. We'll talk a little bit about that. And then kind of the payer joinder administration, which is how your employers are actually jumping into this program and actually do have a direct agreement with the providers. We develop then provider directories, just like any other network type structure would, so that your members know where to go seek tier 1 or contracted services. And then one of the things that we're excited about is the product development side. So this Level Fund Direct that we're kind of reviewing now is a great representation of that. So building programs and products in markets where we have direct contracts to make sure that it is easy for you as advisors to distribute this amongst your clients and prospects. And then we are working feverishly as we are in the new transparency age of healthcare, working with the various vendors out there to make sure that we are producing accurate machine readable files so that the extent that you are leveraging that type of technology, that your members are able to identify care and even have a good idea of what the costs associated with that care are going to be. And so we do highlight that we have what we refer to as our embedded marketplace. Now, we do offer more than one product, and quite candidly, we can work with employers of all shapes and sizes. We have relationships with over 30 reinsurance carriers. Today, we have 26 TPAs that are fully integrated with Health to Business and are actually growing. I've just gotten 2 more orders, so we'll probably be well over 30 by the time we get to the end of the year. And one of the TPAs that we'll be highlighting in today's discussion is Professional Benefit Services, who's been a wonderful partner to this model, really embrace it, and they do a fantastic job both for employers and providers. So let's kind of start to get into the product side now, because I think this is where we can really, kind of learn what's it like to potentially participate in Level Fund Direct. And so as we go through this kind of one item at a time, we'll certainly provide that information. If we move on from a section that you felt we needed to cover in a little bit greater length, please go ahead and submit that question. We're keeping an eye on that on the background, and then we'll circle back at the end and make sure that we get all of those questions asked and fill in those gaps. So the first part is we want to highlight the fact that this is a direct program. And so for us to be direct, we have to have providers that are contracted. And so this page really kind of highlights, some of the different entities that participate. To give you a little flavor of kind of how we approach this, we think of it as starting inside out. So establish the relationships with both Mercy and St. Elizabeth, and then in a coordinated manner, collaborate with them to identify which other providers need to be invited to the program. Our intentions are to make sure that this is robust access. So to the extent that we can cover every specialty and subspecialty, and then ensure that there are enough access points across the greater Cincinnati area, that is really what we were striving for when developing the network, if you will, for DirectHealth Connect. And so this just gives you a little bit of a flavor of some of maybe the more prominent names that you would be familiar with on a localized basis, but there's many more in addition to what you see on this page. So we can get you access to our directories if that is something that you're interested in, and even some of the supplemental networks that we work with as well. Some of the features around this Level Fund Direct program, and I think these are areas that we really feel are important to highlight, is what's in it for your clients, what's in it for their members. Why should an employer consider this, and what are the advantages against maybe a more traditional insurance model? Well, certainly financial savings is a component of it. As we all know, healthcare is not getting any less expensive. And so employers, looking at this type of a model, assuming that they do pass the underwriting requirement, should expect that they are going to see a financial gain against kind of the dollars that they're investing today. Often that ends up being upwards of 15 to 25% when compared to the renewals. And so as you can imagine, that becomes just a compelling value proposition to your clients right out of the gates. The fact that there are direct contracts embedded in the program, and that the employers really do feel like they have a relationship with these community health systems, we think that that's kind of an unusual value proposition. If you think about it, most employers or brokers for that matter have never actually sat down with the health system to discuss what it's like to purchase directly. And so this really is that first opportunity for them. And it may feel a little bit like unusual, but we also believe that there's a lot of value in those relationships and those direct engagements. There is reference-based pricing involved. We do use that as kind of a wrap to both our direct contracts and the supplemental networks that we put in place. And as I always say, that's to close the back door. That is to protect these employers when catastrophic loss does take place outside of our contracts. So we want to ensure that these plans are sustainable and viable for the long term. And so by utilizing reference-based pricing, it allows us to do that. This is not a heavy-handed approach to RBP. And it happens very seldom. We tend to see that most of our clients achieve in excess of 90% utilization under the direct agreements. But should they go to another provider, that's fine. We don't limit that access. We encourage that they do utilize healthcare, obviously. But should there be some dispute with the providers, then our vendors work very hard to kind of mitigate any noise around that and eliminate as much kind of nuisance to the member or to the plan that they can, to the extent that the provider is willing to have a conversation. Certainly RX management. Yes, go ahead, Patrick.
Well, Doug, I was just going to say, I think it would be important to also highlight the relationship that we have with Prime Health and how that's embedded in the program, and how the RBP is only for facility related charges. So we're talking less than way less than 1% balance bill kind of expectation. And then our, future plans with Medical Mutual.
Sure, absolutely. Yeah, so we're not so stuck in our ways that it's contracts or else. We actually kind of deploy a philosophy that says RBP as the option of last resort. And if you really look at kind of healthcare and what's driving so many of the increases for employers and leverage trend, it actually is being borne out of, catastrophic claims, those that take place in facilities, cancer treatments, infusion therapies, or certainly on, some of the specialty drugs that we see out in the market so prevalent today. The practitioners themselves really are not the problem. And in fact, we want to make sure that we ensure access to as many quality physicians as possible, whether contracted or not. And so in addition to our direct agreements and all of those practitioners that it kind of encompasses, we've also included Prime Health Services. Prime is a organization based out of Tennessee. They specialize in kind of, network development. And one of the networks that they have developed is a practitioner-only network. When we've run kind of the reports from a localized level, if you look at maybe a 30-mile, 40-mile radius of greater Cincinnati area, we're in excess of 10,000 contracted or network providers. And all of those benefits are assessed on a tier 1 basis. So when we get into the plan designs, we'll cover that again. So as you can imagine, it's really almost difficult to go get services at a tier 2 facility, right? The St. Elizabeth, Christ Hospital are a couple where that could potentially happen. But our experience has been is that they're actually quite good to work with when these situations come up. So thank you, Patrick. I appreciate you bringing that up. Back to RX management, that is a component that we'll talk about a couple of features that we think are really important here and also refreshing. I think that your employers will appreciate also how we get drugs free for members in many instances and often at no cost to the plan as well. And then this is a level funded program. And I think that's always important to note, one, so that they understand kind of the financial mechanism by which they are, financing their health care, but also to understand that there are, a handful of compliance concerns that may go along with that you would want to address with your clients and prospects, such as, PCORI filing fees, 1095 filings. Those are the types of things that, we just think it's important. Our TPA on the program is there to assist you with that, obviously, but we just want to make sure that you cover that with your clients. From an employee perspective, enhanced benefits. If anything, it may even just be perceived as benefits. So many folks, I think, at this point are staring at $9,000 deductibles. And let's face it, most of us probably don't see much value in that because it could still mean bankruptcy for us one way or another. And so we've really kind of brought back this idea of this is an employee benefit, and we do encourage that you utilize that benefit, develop a relationship with your provider, and seek services from them so that we can start to think of this as more of a well care model versus a sick care model. And then open access, going back to the idea that not only do we have the direct contracts, but then we're wrapping that with the practitioner-only network, right? We're really trying to make sure that members know that, hey, you can seek and access care, but even if for some reason they're not contracted or part of the network, we still allow access to all providers, just like in a traditional reference-based pricing model. So very few limitations are placed in front of the members, just enhancements from benefits, both on a tier 1 and tier 2 basis. Let's cover a couple of the very key best-in-class vendors that we have attached to this program. First and foremost, Health to Business as kind of the program manager and direct contract administration. We'll certainly put Patrick with Direct Health Advisors. He really is kind of frontline distribution here in the greater Cincinnati area. So we encourage you to direct, pretty much most of your questions to him first. But obviously we're always here to support you, in whatever you need. And Patrick knows where to find us as well. From a tier 2 perspective, right, when it's not a Health to Business contract or Prime Health Services, then we work with Zealous very closely. Many of you may think of them as Payer Compass. Zealous acquired Payer Compass here a couple of years ago, but it truly is the Innovate 360 program, if you were familiar with that, where it's 150% reimbursement for facilities, 130% reimbursement for practitioners. We also have the advocacy division that, full advocacy is included in this. And then should there be any dispute where unfortunately it does go to collections or any attorney efforts whatsoever, then an attorney will be assigned to the member via Zealous's legal support. So it really is a kind of a full boat reference-based pricing, even to the degree it is utilized on a very, very limited basis. For our PBM, we are using TrueScripts. They have proven to be a great partner. They're doing some very innovative things on a national level, but then even on a local level as well, where not only are they leveraging the likes of MAP and PAP programs, manufacturing assistance or patient assistance programs, they're leveraging international through RX Manage, and even coordinating with some of the providers here in Ohio and Indiana to provide medications back to members at a significantly reduced costs. And we'll get into that a little bit more, but one of the great things about our program is that we kind of mandate participation of members engaging in like a white glove concierge service when they have high dollar or specialty medications. But at the end of the day, if and when we are able to gain access to lower cost or free medications, the member is going to also receive the ultimate financial benefit that they will have no cost share. So there's a significant incentive to engage in the program. And then maybe almost more important than anything is the administrator of the program. PBS, Professional Benefit Services. They're based out of Salem, Oregon. This is a family-owned TPA, and although they are a little smaller and maybe you haven't heard of them before, they deliver an experience that is unlike very many other TPAs out across the country. It is very hands-on, and their philosophy is that they invest in automation so that to the degree that they can keep claims flowing through and most of the other day-to-day processes, that allows them to spend more time on the phone with their members, addressing your needs and holding your hand whenever you have a challenge on your healthcare journey. So far, they've produced not only a great experience back to the members, but also are a wonderful resource for both the plan administrators as well as our advisor partners as well. And then last but not least is Radion Health. Some of you may be familiar with Radion Health. They are the sister company to Verikai, which is an artificial intelligence underwriting technology. And both of those organizations were acquired about a year and a half ago by Great American, a Cincinnati-based reinsurance carrier. So this really does have local roots from a reinsurance standpoint, that Radion serves as the managing general underwriter. So when submissions come in through Patrick or Cornerstone, ultimately we'll turn those around and coordinate with Radion Health through their artificial intelligence to then work to produce a proposal for you and your client. So they've turned out to be a wonderful partner, really love this model, are embracing it. And one of the major reasons is because Great American feels that this is their opportunity to help their own community from a healthcare standpoint on the financial perspective. All right, so plan design, and this is just a little flavor. Within this product itself, we have kind of 4 dedicated plan designs that hopefully address most issues of most people. We just don't feel it's necessary to provide tens of thousands of options when at the end of the day, we can get almost to zero. Well, why wouldn't we just do that if we can still be competitive, even against some of the more higher dollar, deductible and out-of-pocket plans that are out there? So this is what we think of as copay direct. And it really is, as you can see, it's the direct providers through DirectHealth Connect, which is a combination of our direct agreements as well as the Prime Health Services practitioner-only network. And then as you can see, tier 2 benefits are really those that ultimately have to go through reference-based pricing. But you'll notice that from a philosophical standpoint, right, we're not punishing members if they don't go to a direct or contracted provider. We think of this as more of an incentive-based plan design where, hey, if you go here, we're going to almost eliminate health cost share to the members almost entirely. We do actually have a product, a plan design called Complementary Direct, which is just that. There is no cost whatsoever to members, so that'll be reflected in any proposals that we would send you. But as you can see here, we really encourage utilization at the primary care level. No cost on a tier 1 basis, and that includes diagnostic services. So your members know that they can go seek services from their primary care physicians, and they really should never have any cost share as they're walking out the door. Even for specialists, that's just a $20 copay. Same thing, diagnostic services are included with that. Urgent care at $10. To the degree we can keep people out of the ER, we would like to do that. And so that's why you'll see such a low cost share. Hopefully members are willing to drive just an extra few miles to go find a more convenient urgent care, where certainly costs of the plan are less as well. And then should the member find themselves needing advanced imaging, whether on a standalone basis or at a facility, it's just a $250 copay. No deductibles whatsoever on the plan, not for practitioner or facility services. And as you'll see on a tier 1 basis, regardless of where they're receiving these services, it's a $2,000 maximum out of pocket, which applies to the medical services only. We'll get into the RX deductibles or out of pockets here in a moment. Emergency room is $250, and that does not matter if it's tier 1 or tier 2. So we are ACA compliant in that fashion. And again, that will cover all of the diagnostic services that are included. If for some reason you are admitted to the hospital, then obviously you would start on the daily copays or the deductible and coinsurance, depending on which tier you were in. For contracted providers or facilities, you can see on an inpatient hospitalization, that is $400, and that's on a per day basis, again, up to the $2,000 maximum. Same thing for outpatient hospitals, $400 cost share is what it is for the member. Should they seek services at a contracted ASC, a freestanding surgery center, there is no cost for that. That is the incentive that we wanted to put in place, so that members knew that, hey, if I want to go seek services from a lower cost and often higher quality center, then there's really the ultimate incentive of a free service when they go and do that. And then one of the areas that we like to really focus in on, and I was actually talking to Shelley before this call about it, is labor and delivery. And we've never really understood why it is that when we have these young couples that are going out, to start their families, that in addition to diapers, wipes, and sleepless nights, you get 2 deductibles and 2 out of pockets, which for many of these young people is putting them in financial peril right at a very young age. And so our program is really designed to encourage the growth of these family units is one way to look at it, but to also develop some loyalty back to Mercy and St. Elizabeth, so that, someday when your plan member is driving down the road and, their wife is sitting next to them in the car and Junior's in the back, mom and dad are sitting in the front seat chuckling about the fact that, hey, that's the hospital where we had Junior for free. So the $400 copay applies to mom, and there is no charge for the kid showing up. So that's how we look at that. If we look at then the tier 2 benefits and how those perform, as you can see, it's a really for most practitioner services, it's a copay of either $30 or $50. And then we waive the deductibles on that. For any of the diagnostic services, it's just the 30%, after deductible. $2,000 deductible with a $5,000 out of pocket, and for pretty much anything facility based, it's 30% coinsurance. Many of us have probably seen this plan design 100 times in our career. We've all sold it to employers, and many of them purchased it very willingly, expecting that they were providing their employees a good benefit. And so, as we said early on, right, we're not here to punish people for not going direct. We want to give them just the ultimate incentive to make that decision.
And Doug,
Go ahead, Patrick.
Doug, I was just going to say the out-of-pocket maxes, they cross-accumulate towards one another. Just wanted to be clear on that. So if you happen to seek care at a Mercy St. E's facility and you've met your out-of-pocket max, or conversely, if you've met your out-of-pocket max at a tier 2 provider that does work across the street, let's say, you would not have any out-of-pocket to satisfy going to your tier 1. So not like a traditional medical plan where the in and out of network do not cross-accumulate towards one another. These actually do that.
Yep. The idea is go utilize healthcare and have it be known what your worst case scenario is. So thank you, Patrick. I appreciate that. As we discussed from the prescription side of it, TrueScripts is the PBM. And so you would notice if you went and looked at their network that it's very robust, and just about every pharmacy on a localized basis is participating. And so from a benefit standpoint, we do have 30-day retail. We also have retail or mail at a 90-day benefit. and you can see kind of the co-pays associated with each of those. We really do focus on trying to keep members, lower costs. So of course there's step therapy programs. But as I mentioned, for any high dollar drugs, usually about $500 or more, or specialty medications, you will be required to work with an advocate. And again, this is really designed to be more of a kind of a white glove concierge type experience. So don't let that concern you that this is going to disrupt the member's ability to get their medications. It does not slow that down. It is really an opportunity for TrueScripts to step in to see and identify if possibly there's another drug that's less expensive and has just as high of an efficacy. So they'll work very closely not only with the member, but as well with the pharmacists, any practitioners that are involved. And if there is the opportunity through a third party to get financial assistance, then they will also coordinate everything on that side. What we hear back from most of our plan administrators and plan members is that it is a fantastic experience, and they ask, why don't all PBMs operate this way? So again, don't be intimidated by it. We think it's nothing but benefit that comes along with it. Specialty medications, you'll see even in that instance, it's $100, kind of per fill. And we do offer an out-of-pocket maximum of $1,000. Sometimes members have only an RX need and utilize very little in healthcare, and so we just feel that why should we saddle them with really high out of pocket? So they are separate. So the worst case scenario, if somebody had a lot of medical and they were on a tier 2 basis, plus high dollar prescriptions, would be $6,000 out of pocket maximum per year. If they're able to keep all of that in a tier 1 basis, still have high dollar drugs, then it's $3,000. Which you kind of compare that to most plans out in the market, and it's probably a fraction of the out-of-pocket costs of most other programs. We do highlight what the card looks like here. This is with PBS. It's actually a very nice card. We get a lot of compliments from the provider community because it's easy to understand and see. You'll notice that there is an H2B logo on there, and then there are some also that have a DirectHealth Connect logo. And so that would be something that you should expect on your cards. To the degree the employer would like their name on it, then that's wonderful that we can go ahead and put their information on so that it really does feel like it's personalized to them. Just saw a question here from Shelley, and perfect timing to kind of hit on that. All of the co-pays accumulate towards the out-of-pocket maximum. If there is a deductible associated to any co-insurance, everything is accumulating towards that. So you really can be reassured that on a tier 1 basis, it is a $2,000 maximum out of pocket, or $5,000 on a tier 2 basis. Same for RX, meeting that $1,000 maximum. All right. Patrick, you want to cover the case study? I always think you do a wonderful job. You know this group well.
No, yeah, this is, I think we have the Idaho one on here as opposed to the Northern Kentucky one. We'll get that adjusted. But yeah, it looks like, or Doug, why don't you go through this one, because we've got
okay, no problem. Yeah. So this was an employer coming out of the transportation industry with 71 enrolled employees. They were offering 5 plans that had a range of anywhere from $1,500 to $5,000 deductible. With really only 6 of the members, right, less than 10%, being on kind of the highest dollar benefit. And so, people were self-selecting to move down to kind of, a higher deductible health plan, obviously, to reduce their premiums. As we looked kind of at, well, what were the costs of many of these, these plans that were being offered? You can see here that, we had some pretty high dollar amounts where, on a family unit basis, we always like to point this out, that people were spending upwards of almost $2,000 per month to be on the plan. Sure, the employer may have been covering $600 or $700, right? But that is still, $15,000 out of pocket to a member that they were spending to have their family covered. And so they moved into the DirectHealth Connect program on Level Fund Direct. And as you can see, there was a significant adjustment that then took place from a premium standpoint, as well as going on to the plan design that we just highlighted for you, which was the 0 deductible plan. The employer ended up offering just the one plan. They felt that it wasn't necessary to kind of create all of that confusion that they had in the prior years. the premiums ultimately went down, and there was a significant net savings to the employer. But as you can see, just as important, the savings that on a family basis, where we took almost a $2,000 premium and reduced that to $1,300. So members were seeing an over $650 per month savings, as those are dollars right back in the employee's pockets. So not only did the employer feel good about the fact that they were saving, upwards of 130,000 or more, right, on an expected basis, but also that their employees were able to kind of benefit from a financial gain. And then certainly in addition to the zero deductible health plan that was really finally encouraging access, this was really kind of a godsend to this employer. Our proposals do highlight what we think of as a prospectus. So a lot of the information that you see on this page, you will also see on your proposals to the extent you've shared current information, because what we're trying to highlight is that there's a long-term sustainability that goes along with this. Not only do you save money out of the gates, but because we're controlling spend on both the RX side, and then we're indexing our increases against both the provider's cost increases, which are usually around ordinary inflation, or Medicare, also around ordinary inflation, we've all but eliminated leverage trend. And so as a result, you should expect to see lower renewals on an annualized basis moving forward, which, as you can imagine, just continues to kind of capitalize on those gains. They compound year in and year out. All right, so that was kind of the product side of it. Now, what I think it's obviously important, what if you have an employer that's maybe interested in this program? Again, on this page, we put 10 to 200. That really is kind of specific to Radion and the size of employer that they're focused on. We can work with employers of any size. We have groups that are very large, currently engaged with the likes of Home Depot and others out there. And so I think that does highlight that we can certainly handle both large and small. But for Cornerstone, we really wanted to highlight the Level Fund Direct product. So 10 to 200 is a great way to think of it. The employers that are coming into this are both fully insured or level funded. We see both on a pretty regular basis. From a submission standpoint, if you want to send that to submissions at MyH2B, note that you're part of Cornerstone. If you would like to submit it to Cornerstone directly like you normally do, that seems to be how most of the advisors tend to be working. Either works for us fantastically. Just as long as you get it to us and make sure that we know who this should be assigned to, that's really the extent of what we need on that side. Group name, address, and to the degree that you can provide their industry code, then we'll go ahead along with an effective date and a member level census, which is key in this. We have to have a member level census of those enrolled. Why is that? Well, because it is AI underwriting. Instead of just looking at here's what we filed with the local insurance commission, or experience underwriting, what is happening is they're taking that member level census, they're dropping it into the AI-based underwriting system, and in essence, they are producing a risk score for each individual member that would be enrolled on the plan. They then aggregate all of those risk scores together to come up with an aggregated risk score for the group. And it is about 70% of the time that the group comes in within the threshold to say this is a good risk. They should be, likely they would be a good candidate for self-funding or level funding. And so we would then produce a proposal for you at that time. So, name, gender, date of birth, and then the full address. And when we say full address, that's offering the street number, the street name, in addition to, the zip codes that we've just gotten in the past, to ensure that these are the members that we believe they are. And all that really does is improve the underwriting process in most instances. We like to know who they are for the kids and the spouses. And then which enrollment tier are they in as well, whether it's employee, employee spouse, employee children, or family. To the degree you can provide us prior renewal information and then the current information, that's great. That does help us establish a trend line, again, for prospectus purposes, and then kind of current pricing as well. So if you can get us the tiered pricing for each of the plan designs, we'll plug all that information in and, again, be able to bring that analysis back to you and your clients and prospects. If the employer is currently self-funded, any experience information that you can provide would be greatly appreciated. that goes into helping us underwrite, and then any additional information. We do a lot of business with Radion. We have a great appreciation for the relationship we have with them and vice versa. And as a result, they are willing to have a conversation in instances where, maybe we know that there's a member on the plan that has some higher risks, higher drugs, but maybe something is taking place to kind of offset that risk, and Radion's willing to work with us to make sure that they can get a fair price for each of these employers wanting to participate in DirectHealth Connect. All right, so that really is kind of the highlight of the program. So Patrick, I'll ask you if you have any questions, and then obviously turn it to the group as well for anything that they may have.
No, thanks, Doug. Yeah, a couple things that I just want to add to the presentation. So my role is I work with your rep from Cornerstone. So once an RFP comes in, Doug and his team at H2B will put the RFP together. They will send it out to Radion to get final pricing based off of that dependent level census and the other information that you provided. So one of the great things is that there's no form fire needed. So no form fire. How awesome is that? So we can, if you're prospecting on a new group where it's really hard to get that form fire going, as we all know, you're not going to have to worry about that. It's a lot easier to get that dependent level census. And we can turn around quotes within about 3 to 4 business days, sometimes even as quickly as 2 days if a rush is absolutely needed. And another thing, I am here to help you close deals with DirectHealth Connect and to be a subject matter expert locally. So if you have an in-person meeting that I can be helpful with, because you are just learning about this program, from your experiences today and beyond, I'm here to help you help represent DirectHealth Connect, so I can join you at any in-person meeting with your Cornerstone rep or by myself, or join you on any virtual calls. We've had great success also bringing in Mercy and St. Elizabeth administrators into meetings. They can really help if you think that would be an important aspect of the meeting. It makes the broker shine, being able to have the pull to be able to bring in a hospital representative. So I can accommodate that. Also, we can pull in PBS, the TPA. We had a great call with Shelley and her team with PBS and a prospect that they work with, and they did a great job putting the employer, the CEO of the company, the HR director, and the CFO were all on this virtual call and had all their questions answered very satisfactorily. And we're also able to, move forward with us. We're bringing them on for a 6/1 effective date, about 55 total employees on the plan today. So the last thing I want to mention also is we are onboarding. We already have a partnership with Medical Mutual. So Medical Mutual of Ohio is able to wrap around our direct contracts, which is very unique in this space. So I think we're the only ones that are able to do this. So we have full practitioner and facility access through Medical Mutual with DirectHealth Connect direct contracts, also in play for Tier 1. And it's either going to be, I think, 8/1 or 9/1 is when we expect this to be available for quote effective dates. You will have no reason from an access standpoint, if you're at all hesitant about reference-based pricing, having this Med Mutual opportunity to be embed or to wrap around our contracts is going to make this compete extremely well with any of the BUCA carrier small business solutions that are currently out there. So we've got really great cost containment programs in place with our direct contracts, which are very strong. We've got the RX management. We think we can save 50 to 70% on your current RX spend by using manufacturers, patient assistance programs, international sourcing, and leveraging 340B pricing to help get those very expensive medications that are driving up everyone's renewals and driving up everyone's costs year over year. We're able to get those at the lowest net price to the individual and the group. And most of the time, the individual is able to receive those medications at zero cost, as opposed to paying the $250 plus copays or 100% of the cost if they're on an HSA plan. We also have HSA, HDHP qualified plans that you'll see in the proposal that do have steerage components towards our tier 1 providers and a pretty standard plan design, market standard plan design for our tier 2. So yeah, we really look forward to working with you on this. I think the best way to get started in this is to ask your Cornerstone rep for a DHC proposal, and once if something comes back that looks good, then we can start unpacking it and going from there. But I would like to add that we need, from a decision-making standpoint, let's say 6/1 is right around the corner. If we need to get the green light. This is not like a BUCA carrier where you can submit final information the day before the effective dates and get this thing going, the next day, even though it's going to take several days for it to be, for ID cards and everything else to be implemented. We need at least 2 weeks from when the final determination is made in order to get things up and running, because PBS likes to have everything claim ready as much as they can, as close, if not on the effective date as possible. So that's kind of that's how they do business. They don't want to be like a BUCA carrier where they have ID cards not available for 3 weeks after the effective dates and putting everyone kind of at risk for bad, start to a new relationship. So I would recommend, if you are going to look at this at your renewals, to start talking to your groups about this at least 2 to 3 months out, if not more. Just laying the foundation. I'm happy to join you in those meetings, or you can bring some collateral pieces that will provide Cornerstone to distribute to you, and just to lay the foundation. And then, because it's so easy to get a quote, you do not need to rely on FormFire. You should be able to generate that dependent level census well in advance. So start thinking about this stuff a little bit more in advance for some of you than others, where you're able to get final decisions made on this, because it will take a meeting or two to educate them on this properly, for them to do their due diligence, make final decisions. So we'd love to get at least 3 weeks, but we can do 2 weeks, and in an emergency basis, we can do 1 week, but we don't, that's kind of on an exception basis. I think that's it on my end, and just really appreciate Cornerstone putting this together today. Shelley and Lindsay inviting us in today, and we look forward to working with you on any new cases that you think would be a good fit for this. There's a couple questions in there, Doug.
Yeah, actually, I think Shelley's had some firsthand experience as of late with a client of hers that actually has just moved forward. And a little bit larger client had a couple of just very unique issues, very, very hands-on employer. And so we were able to get engaged with them directly and then kind of address some of these issues. So obviously, we kind of addressed the cross accumulation of benefits between tier 1 and tier 2. So that is a feature of this program. Also, she brought up something that I think is important. So if you have a provider for whatever reason that does not participate in the direct contracts or Prime Health services, there is a nomination process which you can engage in. And so on the Prime website, they have an area where you can go in and nominate, and then they also have a form that you can get completed. That can take some time depending on your provider's willingness, but we find that in many instances, the providers are more than happy to engage with Prime, which would then turn them into a tier 1 provider for not only just you, but any other members on the DirectHealth Connect program. So that is a service that's available. And then I do think it is also important, and Shelley points out, in addition to kind of getting everything submitted early, one of the things we like to do is identify, are there any members that are maybe taking high dollar medications before we even go live, as opposed to just waiting for them to walk into the pharmacy and then realize we have a high dollar med. If we can get out in front of that, again, not only do we help assist the member, but should we be successful in that, the member's going to receive that medication free from month one. So that is important to kind of make us aware of that. We typically communicate that at open enrollment, but I do think from, kind of just as being a feature of the program, it is worth noting. With that being said, we're excited for the opportunity for your clients and prospects to maybe get to know Mercy and St. Elizabeth better. So I really would encourage you, as Patrick said, if you have any questions, please reach out to him, reach out to the team at Cornerstone, have a discussion around DirectHealth Connect and the experience that everyone is already having in it. And if you determine it makes fit, we're happy to help support you any way we can.
Oh, and one last thing. It's also very important is compensation. So our standard comp in this is $30 per employee per month, but you can name any comp that you want. We have a broker that has now 2 cases where they're making $60 PEPM. So if you have the ability to increase your comp and still help, make the sale, then feel free to go up higher than our standard quotes, our standard offering on that, and name your comp. So we have the ability to be flexible on that from that standpoint. Usually the groups that have a higher cost embedded right now. So if you had a really young group with very low claims and they're paying $450 a month for single coverage, the $60 PEPM is going to stand out a little more than it would be if it was an $800, average single price, and that still potentially would look good from our standpoint. So yeah, just wanted to be clear on what our comp was, because we know that you're not doing this, pro bono work. You deserve to be paid for all your hard work.
Absolutely.
Okay. Patrick and Doug, thank you so much this morning. We do appreciate you joining us about this product. I think, this is the future of additional carriers and solutions for those employers, and there's only a few key words that you need to hear is they're sick of it. They're done with these egregious increases that make no sense, with no verification, no reporting, no nothing to substantiate why the increase is being given at the percentage level that it is. So we encourage you to reach out to your broker advisors at Cornerstone and ask questions. We've been through a lot of training, and we will quickly get Patrick involved. And then if it's a go, we will move forward with Doug and his team and PBS, the administrator. So I don't think there are any other questions. With that, we'll let everybody go today. Enjoy your sunny Thursday. It may be the only sunny day we get here in Ohio this week, so make the most of it. Thanks for joining us this morning. Take care.
Thank you.
Thanks, everyone.